When suicide is discussed in public health, faith is often treated as a side note, sometimes even as a risk factor. But when we look carefully at the data, the lived experience of communities, and the psychology of despair, a different picture emerges. Faith does not replace clinical care, but when integrated wisely, faith informed approaches can reduce isolation, restore meaning, and strengthen protective factors in ways that purely medical models often cannot. Today, we're going to explore what actually works, not in theory, but in practice, when faith communities engage suicide prevention responsibly. 1. Reframing suicide from moral failure to human suffering. One of the most damaging barriers to prevention, especially in religious communities, is moral framing. When suicide is understood primarily as sin, weakness, lack of faith, people hide. What works instead is a theology of suffering, not a theology of blame. Across faith traditions, we see a shared insight. Humans can experience anguish so severe that hope collapses. Despair is not rebellion, it is often exhaustion. When communities teach that struggle does not negate worth, help seeking increases. What works? Teaching that despair is a human condition, not a spiritual defect. Naming lament, grief, and anguish as spiritually legitimate experiences, separating moral worth from psychological capacity. This reframing alone reduces stigma, one of the strongest predictors of delayed help seeking. 2. Belonging before belief. Community as a protective factor. One of the most consistent findings in suicide research is this: perceived belongingness is protective. Faith communities excel here when they function well. What works is relational presence, not doctrinal correction. People at risk rarely need a sermon, an argument, a theological explanation for suffering. They need to be noticed, to be remembered, to be missed. If absent faith communities that track attendance compassionately, follow up relationally, normalize check-ins, encourage shared meals, rituals, and service, create buffers against isolation, which is a primary driver of suicidal ideation. Key insight: belonging saves lives long before beliefs change. 3. Meaning. Making after moral and existential injury. Many people who die by suicide are not simply depressed, they are morally or existentially wounded. This includes veterans, healthcare workers, survivors of trauma, individuals carrying guilt, shame, or perceived moral failure. Faith traditions are uniquely equipped to address this because they offer narratives of forgiveness, restoration rather than erasure, redemption without denial. What works is moral repair, not reassurance. Examples include rituals of confession and release, practices of lament, naming tragedy without forcing resolution, teaching that worth precedes productivity or purity. When people can reinterpret their suffering within a larger moral narrative, suicidal ideation often decreases, even when pain remains. 4. Clergy as gatekeepers, not therapists. One of the most effective faith-based interventions is also one of the simplest: training clergy and lay leaders to recognize suicide risk and refer early. What does not work? Clergy attempting to replace mental health professionals, spiritualizing away symptoms, advising secrecy or endurance without support. What does work? Basic suicide risk literacy, knowing warning signs, asking direct, non-judgmental questions, normalizing referral as an act of care, not failure. Faith leaders are often the first trusted contact, especially in communities that distrust medical systems. When clergy function as bridges rather than barriers, outcomes improve. 5. Integrating faith with clinical care. The most effective models are integrative, not competitive. This means encouraging therapy and medication when indicated, framing treatment as stewardship of life, supporting adherence rather than discouraging it, coordinating care with consent. Faith becomes a protective supplement, not a substitute, Evidence shows that when individuals experience spiritual support and professional treatment and sustained relational care, rates of recurrence drop and recovery improves. 6. Post crisis presence. The forgotten intervention. One of the highest risk periods for suicide is after discharge from emergency or inpatient care. What works exceptionally well in faith communities is continued presence after the crisis, non intrusive check ins, practical help, refusal to disappear once the emergency passes. Many people report that what kept them alive was not a hotline, but someone who stayed. Faith communities are structurally positioned to do this well if they commit to it. Closing synthesis. Faith informed suicide prevention works when it does 5 things well: reduces stigma instead of increasing shame, creates belonging before demanding belief, offers meaning without minimizing pain, partners with clinical care rather than replacing it, stays present after the crisis fades from view. Faith does not cure suicide, but faithful presence, moral repair, and relational commitment save lives. The goal is not to preach people out of despair, but to walk with them until hope becomes possible again.